Good night. My name is Daniela Tobalina and I'm going to talk about IDH2 mutation in a patient with metastatic colon cancer. First of all, I'm going to talk about the introduction. The main reason that cancer is so serious is its ability to spread in the body. Cancer cells can spread locally by moving into nearby normal tissue. Cancer can also spread regionally to nearby lymph nodes, tissues, or organs, and it can spread to distant parts of the body. When this happens, it is called metastatic cancer. For many types of cancer, it is also called stage 4 cancer. The process by which cancer cells spread to other parts of the body is called metastasis.
Welcome to the CRC Resource Center, presented by the Angiogenesis Foundation. This animation describes colorectal cancer and the role of angiogenesis in cancer development. Colorectal cancer, or CRC, is the fourth most common cancer in men and women, usually diagnosed in people aged 50 years or older. It occurs in the colon, which is the large intestine, and also occurs in the rectum, which is the connecting pathway between the colon and the anus. Colorectal cancer typically develops from colorectal polyps, which are abnormal growths that develop silently inside the colon or rectum. Although most polyps will not become cancerous, some may develop into cancer. Type, location, size, and the number of polyps are related to the risk of developing colorectal cancer. Individuals with a family history of polyps may also be at higher genetic risk for developing polyps, and therefore at higher risk for colorectal cancer. When caught early through preventative screenings, polyps are removed, which can prevent the development of CRC. If they are not caught early, some polyps can become cancerous. Tumors can eventually grow through the colon wall and may spread into the surrounding tissue or to other parts of the body. When cancer has spread to distant parts of the body, it is called metastatic colorectal cancer. The most common sites of colorectal cancer metastases are the liver, lung, and bone. Solid cancers have been shown to depend upon angiogenesis, the growth of new blood vessels from pre-existing blood vessels. A tumor that is in its early stages of development cannot grow past a few millimeters in diameter unless blood vessels supply it with oxygen and nutrients. In this way, blood vessels serve as lifelines to cancer cells. How does it work? Cells in the center of the tumor mass have to compete with their neighboring cells for access to oxygen and nutrients. When they begin to starve, they release growth factors as a distress signal to the surrounding tissue. Nearby blood vessels receive these signals and begin to grow new vessels toward the source. As long as the signal continues, the vessels will continue to grow in its direction. Vessels that grow into the tumor nourish the tumor tissue, delivering oxygen and essential nutrients, but are structurally abnormal. As the tumor grows larger, signaling may increase and encourage even more blood vessel growth. As the tumor expands, it invades surrounding tissue. Cancer cells spread as metastasis through the blood vessels and lymph nodes, then to distant organs in the later stages of CRC progression. Colorectal cancer can take years to develop and rarely has any symptoms in the early stages, which is when it is most treatable. So it is important to be consistent about getting annual screenings after the age of 50 or as determined by your doctor. If you or a loved one has been diagnosed with colorectal cancer, learn about your treatment options in the next video and know how to work with your doctor to ensure you receive the highest quality care.
Okay, now I'm going to talk about the applications in medicine. What are the genes IDH1 and IDH2 application in medicine? Genes encoding for IDH1 and IDH2 are frequently mutated in multiple types of human cancer. Mutations targeting IDH1 and IDH2 result in simultaneous loss of their normal catalytic activity, the production of alpha-ketoglutarate, alpha-KG, and gain of a new function, the production of 2-hydroxyglutarate 2-HG. Abnormal histone and DNA methylation are emerging as a common feature of tumors with IDH1 and IDH2 mutations and may cause altered stem cell differentiation and eventual tumorigenesis.
IDH mutant positive cancers, IDH mutant enzymes acquire a new or neoenzymatic gain of function activity that may disrupt normal cellular metabolism. The IDH mutant enzyme dimer has a normal and a mutated copy. The normal copy generates alpha-ketoglutarate. However, the mutated copy takes alpha-ketoglutarate and converts it to the oncometabolite 2-hydroxyglutarate, or 2-HG. This reaction consumes NADPH, which may increase reactive oxygen species and thus promotes oncogenesis. This leads to an accumulation of 2-HG levels within the cell. The excess production of 2-HG can disrupt the function of cytoplasmic and nuclear alpha-ketoglutarate-dependent enzymes. This disruption occurs because of the chemical similarity between 2-HG and alpha-ketoglutarate. 2-HG binding to alpha-ketoglutarate-dependent enzymes prevents their ability to demethylate DNA and histones. Therefore, elevated levels of 2-HG are associated with the abnormal methylation of DNA and histone proteins. Research suggests that hypermethylation of DNA and histones alter the transcription of key genes, including those necessary for differentiation. The result is a block in cellular differentiation and an accumulation of immature cells, which potentially contributes to oncogenesis in IDH mutant cancers.
Okay, now I'm going to talk about the issue applied in Ecuador. According to official figures from the Society for the Fight Against Cancer, SOLCA, approximately 1,200 new cases of colon cancer occur in Ecuador every year. Of these cases, if treated in a timely manner, 52% of people survive. Patricia Cueva, National Director of the National Registry of Tumors of SOLCA, said that of every 100 cases of cancer that occur, 6 are colon cancer. We have a growth of 50% of cases of this disease in the last 30 years.
Right from their onset, invasive tumors of the colon release malignant cells into the bloodstream, potentially causing metastases or the generation of new tumors in distant organs. Metastasis is an inefficient process, however. Only a small number of cells actually have the capacity to colonize other organs. They most often die off, either en route to a new organ or once they have arrived. Although metastasis is an inefficient process, when it does occur, prognosis is poor. 90% of cancer deaths are caused by metastasis. The team of Eduard Patier at IRB Barcelona have discovered that in order for metastasis to occur, a crucial type of cell in the tumor stem cells, must be able to form connections with the stroma, the network of healthy cells in their surrounding environment. This ability is already observed in the primary tumor. Without it, the stem cells in the colon tumor would be unable to metastasize. When producing metastases, the tumor stem cells release TGF-beta into the stroma. The surrounding cells respond by releasing another molecule, interleukin-11, which produces several changes within the tumor stem cell that allow it to survive. Thanks to the complicity of the stroma, the invasive colon cancer cells can produce new tumors.
Okay, now I'm going to talk about the pros and cons. Advantage. Patients with this mutation in their tumors appear to have a better prognosis with longer survival rates. And disadvantage. The challenges of generating the IDH1 and 2 mouse model probably reflect the strong toxicity produced by the tumor-derived IDH1-2 mutant that can severely block normal mouse development.
The selective inhibitor of mutant IDH2 enzyme, AG221, has been demonstrated to reduce levels of the oncometabolite 2-HG to baseline in an IDH2 mutant mouse model. TET2-mediated demethylation activity is known to be inhibited by 2-HG. In the presence of AG221 in vitro, mutant IDH2 activity is inhibited, resulting in decreased 2-HG production, and is hypothesized to restore DNA demethylation via TET2. Mutations in the IDH2 gene have been shown to contribute to leukemogenesis in vitro. In the presence of AG221, it is hypothesized that changes in DNA methylation status may affect changes in gene expression and induce cellular differentiation of acute myeloid leukemia blasts into cells of the macrophage and granulocyte lineage, as observed in preclinical studies.
Okay, and finally, my conclusion. The discovery and subsequent investigation of IDH1 and IDH2 mutations in tumors have renewed interest in research of tumor metabolism. Therapeutically, unique features of IDH1 and IDH2 mutations make them good biomarkers and potential drug targets.
Managing AML. I am Dr. Navla Davar. I am frequently asked what are the latest updates on the IDH1 and IDH2 inhibitor studies. So the IDH1 and IDH2 inhibitors have shown very promising activity in patients with acute myeloid leukemia. The IDH2 inhibitors were the first one to go into clinic about 2 years ago, and now there have been about 200 plus patients enrolled on these studies. The overall response rate is about 35 to 40%, including 20% that are CR and an additional 15 to 20% that are partial responses and hematological improvement. One of the key features we have noticed is that a lot of the responses, including the partial responses or hematological improvements, have been very durable. And so this is a new era for acute myeloid leukemia, where patients who do not achieve complete remission may have prolonged benefit from some of these agents. The other thing with these agents is that they're oral, so easy to administer, and they have minimum toxicities. Actually are extremely well tolerated. We have seen a few instances of transaminitis, and usually it is reversible. So all in all, I think the IDH1, IDH2 inhibitors are a breakthrough for AML therapy, being oral agents, and they target the particular mutations. One of the points to note is that the IDH2 mutation is present in about 8 to 10% of patients, and the IDH1 is present in about 10 to 12%. So they don't cover all AMLs, but they are good options for the 15 to 20% of patients who have an IDH1, IDH2 mutation. Further, these drugs are now being developed in the frontline setting in combination with standard approved agents for AML, such as azacitidine plus IDH inhibitor for the older patients who are not fit for intensive chemo, and then 3+7 or high-dose chemo plus IDH inhibitor in the younger population. And I think these studies will be even more interesting to see if we can get more durable remissions that will then result in early survival by using targeted therapies with chemotherapy upfront.
Okay, thank you very much for listening.